We're here at the IAS meeting with Linda Gail Bekker, who is with the Desmond Tutu Research Center, and it's a pleasure to have you here. And it's really a conference that we have learned a lot, and it's the prevention. I guess some people would call it the prevention conference because we have had a lot of good resolution there. And I'm not sure how that's going to interpret into results and to action in Southern Africa, and that's why I ask you, importantly, to be here to help us with that.
Sure, thanks, Fred. Yeah, I think, like you, I think this conference is memorable for two reasons. One, I think we really solidified our thinking around oral pre-exposure prophylaxis as something we need to implement. And the second was this notion that if we treat people early enough and enough of them, and we get them enough of them virally suppressed, that we'll get some prevention benefit from that as well.
Herd immunity in the community.
Exactly, in many ways. And what that is about is that when enough people are treated and are virally suppressed, in other words, their virus is low, then they're less likely to transmit virus, even if they have unprotected sex with someone else. And therefore, the chances of incidents being reduced are much better. So those two pieces of information, I think, are really key. The other things that have happened here is we've learned about new modalities coming down the line, but like everything, that's interesting to hear about, but it's not here yet. I think the very exciting thing is we've got new things that we can do. The question is, will we do them? And that's the big question in Africa, just simply because we're so overwhelmed by numbers and scale and the extent of our epidemic that we're kind of playing catch up all the time. And now we're asking, can we do more? And that's a big question, I think, for policymakers. But I would argue, yes, not only must we, but we absolutely have to, because we have no alternative. My take on this is that we have to treat all the people that need to be treated, and remember, 2/3 of them are more than that. 70% of them are in Africa. But we also need to find a way to turn the taps off, because if we continue to have new people coming into the treatment pool, this is a never-ending public health intervention.
So we have to hit it now and hit it hard.
Absolutely.
And the more investment we make right now is going to mean much better cost savings down the line, even if we don't consider the humanity that we're dealing in, the health, the lives. Even if we didn't consider that, it's huge saving for governments and infrastructure and people back in their jobs. And it would be another world.
Well, that's exactly it. And also by getting people onto treatment early in their trajectory, in their actual, if you like, journey with HIV, they are far less likely to sicken, need healthcare interventions. So there's cost savings also there. So you have a healthier population, but you also have emptier hospitals, which is obviously a great benefit. So, I like to still think about it as the double cascade. So we have to get testing up and make sure we're really testing in innovative ways. So in Africa, we're exploring testing in mobile units, testing in people's homes, testings in community venues, allowing people to even self-test, buy the test or get given a test and do it at home in a convenient place. And then to really say, it doesn't, whether you test negative or test positive, there's something that needs to be done.
Right.
And if you test positive, it's obvious, start treatment, stay on treatment, get virally suppressed, and forget about it. Life's good. You really, as long as you keep taking your pills, things should really return to normal. And in fact, we heard today that longevity is entirely restored if all goes well.
Especially early treatment.
Yeah. The other cascade, if you like, the other arm is, what do I do if I'm negative? And even there are things that can be done actively. In the old days, Fred, we used to say, oh, good, you're negative, go well, Now we need to say, okay, what is your risk? And what can we do to actively ensure that you don't become infected? And, in my part of the world, probably just about everybody has some kind of risk because there's an awful lot of virus moving around. And so it's about the force of infection. When you've got enough of a burden of virus, even, what would be considered in other parts of the world not particularly risky behavior might be extremely risky in Africa simply because the chances of meeting the virus are so much higher. So we really want to have the conversation with just about everybody. What can we be doing with you? What can you be doing for yourself to ensure that you stay negative?
Because there's more regular risk, more actual regular risk, because the number of people who are infected and who maybe aren't on treatment yet. Should people be treated? I mean, it would seem like people should be tested more frequently, just on that basis alone.
Exactly.
Do you have that in place, or is that something you'd like to see happen?
So the country I come from is South Africa, and our policy there is an annual test for everyone. Now, clearly, you may put yourself into a slightly different risk position if you are monogamous in a relationship, that you may decide, well, perhaps I could reduce that.
But on the other score, it may be more
that
regular.
You may actually want to do it even more regularly. So,
and there is infrastructure to allow for that?
There certainly is. So South Africa, I'm sure you recall, in about 2011, embarked on an enormous testing campaign. And the government decided they wanted to test 15 million individuals over a period of time. I think they made it to about 11 million, which is unbelievable. But in some ways, I kind of wish that it happened now, because I feel like we've got a more active process now.
Exactly.
We've got more we can do with it. There was a time, it was an extraordinary time, where we would say to people, test, and if they tested positive but they hadn't yet sickened enough, we'd say, you know what, go away, and when you get really sick, come back and we'll treat you then.
Yeah.
And,
that was just the way it was then.
Well, and
Today
perhaps some of the listeners are thinking, well, what a dumb thing to do, We now have evidence, and this is what we work on, is we need good evidence, because sometimes public health is complicated and we don't always know intuitively what needs to be done. But we now have unequivocal evidence that really this virus should be treated from the first time it's diagnosed. And so, our task is clear. How will we do that in Africa? And in my country, that means treating more than 6 million individuals. That's an enormous health undertaking. And it does mean we're probably going to have to really be innovative and strengthen our health systems in the most extraordinary ways. So this isn't just about going out, testing people and handing out more antiretrovirals. It's really about saying, let's think outside of the box. And I'm pleased to say, Fred, I think in many ways Africa leads the way in this regard. We recognized a long time ago that we were going to need to task shift. That means, this cannot be only the business of doctors. And it's moved to nurses, and from nurses to lay healthcare workers, and beyond that to civil society. So everybody gets involved. And we have also recognized that care needs to be differentiated. So there are specialized clinics that do special things. There are primary healthcare clinics that do a certain amount of work, but we've actually moved everyday treatment distribution into the community. So this means somebody doesn't actually have to go to a health facility to get a top-up of treatment. They actually just pick it up in the community.
Do they get monthly, or how's that?
So we're actually up to 2 monthly now, and they can send a buddy once, so they can actually delegate somebody else to come.
Right.
So it means people can get back to their lifestyles, they can get back to their livelihoods. They're not spending all day in a clinic to pick up treatment. And over Christmas, actually, our government's agreed we can give them 4 months, so people can go away for a period of time. And we have looked at this because we are evidence-based, and we've not found any reduction in retaining those individuals. There's been no drop-off in viral load. And so the good news is that we seem to be, doing a good thing. So that's the kind of innovation that I think we're going to have to see more of around the world to ensure that, the 40 million we need to treat can do so and continue with their lives.
How do you engage with other countries and with other communities, or however that would be, to express what you're doing as a model for others? I mean, I'm sure we talk about every community is different, but there are some similarities, enough similarities to know that there's things that you can do as a community and that somebody else can do. This, if we learned a lesson,
So
pass
this,
it on.
Fred, this is the important role, I think, of these kinds of
Conferences,
meetings.
yeah. Mhm.
So, you know, I know that our community-based, we call them adherence clubs, that's being presented at this conference.
Mm-hmm.
We obviously write peer-reviewed publications, so that is important to do. But I'm also pleased to say this is something I'm the president-elect of the International AIDS Society, and this is something the IAS is picking up. So we will actually be saying it's time to take best practices around the world. And so we have a particular project to say this, we call it differentiated care, decentralized care, there are other ways of thinking about it, but how do we actually take these models and make sure that other people get to learn and benefit from them? So I do think there's more of that that needs to be done. I don't think we've cracked that, but it's something that we need to get more adept at. And also, this service is wonderful because this is a great way to share ideas in a very broad way with the
Because
world.
I ask you every question I can think of that maybe the community wants to know, and or that they need to know, or that we'd like them to know. But it's so important to get this communication going in a way that is real and not sensationalized, but just understanding that there are things we need to know, how to operate as people who are human.
That's right.
And who have human needs, which is sex and so forth. So learning about, we just had Jared Beaton who talked about the what is success in PrEP, and it's very different for different people in different
Indeed.
communities.
No, I think that is right. You know, and I think we've also come of age to recognize that, and it was said so beautifully at our opening the other evening, that HIV is not just about numbers, it's about individuals and people who live lives and have needs, as you say. And each of them are different, and we need to be absolutely cognizant of that at all times. It is not just a public health intervention. In other words, finger wagging at individuals is really not the way to go, but understanding who they are, how their lives work, how their sexual lives work, and then fitting our care around them is much more likely to realize success and uptake and adherence than, you know, trying to get them to fit into what we think is the model for their lives. So I think we've really come of age in that. I think some work still needs to be done.
And you're in a good position to do it.
I hope so. Yes, very much so.
The future chair of the conference.
Yes.
So it's I'm not sure where you're going to go with it, but I think you're going to do a really great job.
Well, thank you. Well, the next one is in Durban in the year 2016. We're on the road to Durban now. And we're returning to Durban 16 years after the last conference. And the Durban 2000 conference was absolutely critical, and I'd like to tell your listeners for why. And that was because at that conference, we realized that many people in the world were accessing antiretrovirals, but the vast majority of the world were not. And they were dying. And the reason they were dying was they could not get the antiretrovirals. And that inequality, you know, this conference really showed, and it was a wake-up call for the whole world. And here we are now, 16 years later, with 15 million people on treatment around the world. There was no way we even imagined that could happen.
I would talk
2000.
to Dr. DeCock, and he would tell about in Kenya how devastated things were and how we would improve. We interviewed him every single time we did the CROI conference. And it was almost like we wanted to watch them all in sequence because it was such an amazing evolution.
Story.
I mean, from the days when we said they're not going to be able to take treatment because they don't have watches. I mean, how ridiculous. And we proved that some of the people, some of the communities and some of the whole sections of the world that had no watches were probably better following adherence than in places where they had watches and clocks and everything else going for them. And it's just,
well, we purposefully wrote that paper shortly after that statement was made to show that our adherence actually outranked anyone in the world.
Without a question.
And then beautifully, Matthias Seger some years later at a CROI plenary showed how the Swiss response, or the European response, looked, slightly less good than actually the African response, and so that was and it's not a competition. But the good news is that we're getting to a place now where we really are talking about treatment for all, and that is, we need to galvanize the resources, galvanize the innovation, galvanize the industry to get there. But we have at least the evidence that points us that this is the way to go.
Thank you so much for being here.
An absolute pleasure, Fred. You do great work.
It's a pleasure with me too.
Great. All right. Take care.